Hello, everyone, and welcome to this explainer. Okay, let's just dive right into it. Today, we're taking a highly practical, evidence-based clinical journey into a condition that, let's be honest, you see in your practice literally all the time: recurrent urinary tract infections in women. We're going to break down the latest guidelines, look really closely at the underlying pathophysiology, and give you structured, actionable strategies that you can take right back to your clinic today. Here's our roadmap for the session. We'll quickly define recurrent UTIs, explore the risk factors and diagnostics, talk about managing the acute episodes, map out evidence-based prevention, and finally, address some major clinical pitfalls and stewardship. And we're going to anchor all of this with real-world clinical cases. All right, starting off with our first major topic, defining the recurrent UTI. Because before we jump into actually treating patients, we really have to lock down our terminology. Think about your baseline cystitis patients for a second. A staggering 15% of women with an initial diagnosis of cystitis will actually go on to experience recurrent infections. I mean, that is a massive clinical burden, right? It heavily impacts healthcare utilization, destroys quality of life for these patients, and is a huge driver of antimicrobial resistance. So when exactly does a patient officially cross over into the recurrent pathway? Well, the strict clinical definition is 2 or more infections in a 6-month period or 3 or more infections in 1 year. That's the threshold. That's exactly where we transition from just treating isolated, one-off incidents to really needing a long-term management strategy. And we absolutely need to draw a hard line here about what exactly is recurring. You see, in the vast majority of our recurrent cases, in this specific population, we're dealing with acute, simple cystitis. That means the infection is strictly confined to the bladder. This is a totally different beast from an acute, complicated UTI where the infection has extended beyond bladder, maybe up to the kidneys as pyelonephritis, or it involves structural abnormalities, catheter-associated infections, or it's causing systemic illness. It's the clinical presentation that really drives this distinction. Classic simple cystitis presents with the familiar dysuria, urgency, frequency, and suprapubic pain. But the very second your patient presents with a fever over 99.9 degrees Fahrenheit, chills, systemic fatigue, or flank pain with costovertebral angle tenderness, boom, the diagnosis instantly shifts to a complicated UTI. And that completely alters your management and your workup. Now, before we move on from definitions, we absolutely have to talk about asymptomatic bacteriuria, or ASB. This is defined as having 100,000 or more colony-forming units per milliliter of urine, but with 0 clinical features of a UTI. Here is a massive clinical pearl for you. Treating ASB in healthy, non-pregnant women, with pregnancy being the major exception, of course, is a huge clinical pitfall. Bacteriuria without symptoms simply does not equal an infection. Treating it just causes unnecessary antibiotic exposure and drives resistance. Don't do it. Okay, moving into section 2, let's see how all this builds into our actual diagnostic approach in the clinic. To really bring the epidemiology and pathophysiology to life here, let's look at 2 composite patients. Patient A is a healthy, premenopausal woman. Her recurrences are super frequent, often post-coital, and she uses spermicide, which we know is a major factor that alters the vaginal microbiome. Then we have patient B. She's postmenopausal. Her risk factors are a mix of mechanical and physiologic. She has an estrogen deficiency, which essentially wipes out her protective lactobacilli, alongside a cystoscopy and urinary incontinence that lead to incomplete bladder emptying. So 2 very different pathways, but both leading to recurrent cystitis. When you're evaluating these patients, precision is absolutely key. Think about it. If a patient comes in with dysuria, but they don't have any urinary frequency or urgency, what should you suspect? Your line should immediately jump to vaginitis, especially if there's discharge or an odor. And what if the symptoms persist for weeks despite antibiotics and they have sterile urine? You've got to start thinking about interstitial cystitis. The takeaway here is that not everything that burns is a UTI. So when patient A or B inevitably comes back with another infection, you have to ask yourself, is this a reinfection or a relapse? The vast majority of the time, recurrences are reinfections. That means it's a brand new infection following the complete eradication of the prior one. It's either caused by a completely different strain, or it happens more than 2 weeks after treatment. A true relapse, on the other hand, is the reemergence of the exact same strain within 2 weeks of finishing antibiotics. That tells us we never actually cleared the original reservoir, often because of intracellular bacterial communities or biofilm formation. Now, most recurrent simple cystitis cases do not require imaging, but if you see a true relapsing infection within 2 weeks, that is a glaring red flag. Other urologic red flags that should make you pause and order a CT urography or ultrasound include repeated isolation of Proteus species, which, as you know, is notorious for causing struvite stones, a history of passing stones, or persistent hematuria even after the infection is completely cleared up. Let's shift gears to Section 3. Managing the acute episode when our patients have a symptomatic flare-up. For an acute flare-up of simple cystitis in patient A, empiric therapy is going to be our first move. Our first-line oral options include nitrofurantoin for 5 days or a single 3-gram dose of fosfomycin. Trimethoprim sulfamethoxazole is also a great first-line choice, assuming your local resistance rates are low. But notice what is glaringly absent from the first-line list. Fluoroquinolones. We absolutely must avoid these broader spectrum agents up front for simple cystitis whenever we possibly can. And why are we so fiercely protective of our broad spectrum antibiotics? Well, it's largely because of the global emergence of the ST131 clone of uropathogenic E. coli. This thing is a major driver of fluoroquinolone-resistant and ESBL-producing infections worldwide. Literally every single time we unnecessarily use a fluoroquinolone for simple cystitis, we're exerting this intense selection pressure that favors these highly resistant, really dangerous clones. Which perfectly transitions us into Section 4, evidence-based prevention. How do we stop just reacting to every single flare-up and actually start proactively managing patient A and patient B? When we're designing a prevention strategy, it is so incredibly vital that we don't just immediately jump the gun and go straight to daily antibiotics. We need to start at the top, focusing on established behavioral efficacy and non-antibiotic strategies first. We really should only be escalating to continuous prophylaxis if the patient is dealing with highly bothersome recurrences that have failed all other measures. So we rely on a strict 3-tiered approach. Step 1, modify behaviors and increase fluids. Step 2, introduce non-antibiotic prophylaxis, things like topical estrogen, methaminane, or cranberry. And then Step 3, only if those fail do we even consider continuous or post-coital antibiotic prophylaxis. Let's break these down a bit more. For patient A, our premenopausal patient, behavioral modifications definitely include taking a hard look at her spermicide use. But here is a surprisingly simple, yet incredibly powerful piece of data. Just increasing fluid intake to a target of 2 to 3 liters a day decreases cystitis incidence by a massive 50%. Half. It naturally flushes the urinary tract and clears bacteriuria. Honestly, this should be step 1 for every single patient. Now, what about patient B? Because she's postmenopausal, her declining systemic estrogen has completely altered her vaginal microbiome. It raises the pH and basically rolls out the red carpet for E. coli to thrive. Prescribing topical vaginal estrogen directly addresses this underlying pathophysiology. It normalizes the vaginal flora, brings back those protective hydrogen peroxide-producing lactobacilli, and directly decreases E. coli colonization. It is an absolute game changer for this population. If behavioral changes in estrogen just aren't cutting it, we turn to antibiotic-sparing strategies. Methenamine hippurate, taken twice daily, is fascinating. It literally converts to formaldehyde in acidified urine. This creates a totally toxic environment for bacteria without selecting for typical antibiotic resistance. Alternatively, cranberry products can block bacterial adherence, and agents like D-mannose help prevent E. coli from binding to the uroepithelium. In some specific settings, immunoprophylaxis oral vaccines might even be an option. The point is, these are highly effective strategies that we should absolutely utilize before we just default to daily antibiotic pills. All right, let's wrap things up with Section 5, pitfalls and stewardship. Because let's face it, we hold a heavy responsibility every time we write a prescription. If we bypass that tiered system we just talked about and jump straight to Step 3, continuous antibiotic prophylaxis, we risk some immense collateral damage. We select for antibiotic resistance, we further damage our patient's already fragile protective vaginal microbiome, we risk secondary C. diff infections, and honestly, worst of all, we risk losing future oral therapy options entirely when that ST131 clone inevitably takes over. Which leaves us with this final crucial thought. As you look at your own clinical habits, are you still defaulting to fluoroquinolones for simple cystitis? Are you still reflexively treating asymptomatic bacteria just because a culture happened to come back positive? I want to challenge you to take this stewardship message back to your clinic today. Rely on those evidence-based tiers of prevention, and let's protect both our patients and our critical antibiotics. Thank you so much for joining me on this explainer.